Thank you very much for the kind introduction. Actually, only director at the Brigham Women's. It's one of the big institutions of Harvard, but not the entire one. Thanks for coming. Very good morning to you all. Thank you for having an interest in LVADs. I have no financial or conflicts of interest. Now, with the limited supply of transdermal organs and with the emerging technology of left ventricular assist devices, it's no surprise that over the years we've seen, or the patient population with LVADs is continuously growing. Currently, I'd say probably most of them are cared for in special either cardiac care units or cardiac surgery care units. But given that that number is increasing and we're getting more and more busy, I could see that down the road, these kind of patients might end up in a normal or in a regular ICU, as well as they present with problems post-implantation. So it's worth having a look at those devices. We're currently in our third generation of devices. They started early on, about 15 years ago, with first generation devices. They actually were still explanted, while they were centrally cannulated, but implanted actually outside of the body, trying to mimic a pulsatile flow. Then the second generation, such as the HeartMate 2 here, were axial flow devices who were actually, again, centrally cannulated, but the actual device was sitting in the abdominal cavity. And from there, we moved on to third generation devices, which are much smaller devices, and so-called centrifugal flow devices, which are now all the way implanted in the chest. There's basically two kinds of technology. I kind of already mentioned it. There's centrifugal flow devices and there's axial flow devices. Currently, most of them that we use in third generations, they're actually all just centrifugal devices, such as the hardware HVAD, the Everheart, for example, or the HeartMate 3, one of the most frequently implanted devices, at least in the United States and in Europe. And then there's the second generation older models, such as the HeartMate 2 or the Jarvik 2000, which are all axial continuous flow devices, which you still might actually come across. Here, a closer look at an axial flow device, such as the HeartMate 2. Terminology just again goes according to the device, so you have an inflow portion into the device. Then the axial flow devices, basically, they work like an auger. They screw through the blood and just basically just push it forward into the outlet and then into the aorta. It's then only a small drive line, kind of comes out of the abdomen, controlled by a controller and then attached to a battery pack that allows the patient to be mobile. The actual technical setup is very similar to for centrifugal flow devices, such as the HVAD here, but those are centrifugal flow devices, much smaller. They're actually magnetically levitated propeller devices, which basically throw the blood, so to speak, out from the inlet into the outlet. Getting a little bit physical, so to speak, a little bit technical. These are so-called pressure head curves. It's a weird term, but all this means basically is that these flow devices are very operator dependent on the pressure gradient between the inlet and the outlet, so it's either called head pressure or just delta pressure, basically. And that distincts the flow rate that they actually give with a set RPM setting, basically. Steep curve for axial flow devices and more flat curves for the centrifugal devices. Now, what's the difference? Does it matter? I apologize for the poor quality of this image, but the content, I think, is extremely important. As I said, the actual flow that these devices deliver depend on the pressure gradient. And if you look here is a cardiac cycle and a failing heart, what's the pressure difference between aorta and left ventricle in one cardiac cycle? You can see it here. The difference basically varies between 80 and 40 milliliters of mercury. Roughly, how does that translate into the flow of a centrifugal device? At a pressure difference of 80 millimeters of mercury, there's almost no flow provided by the device. And then at the pressure difference of 40, almost 10 liters of flow are provided. Meaning, in one cardiac cycle, the flow actually varies almost between 0 and 10 liters. And that's how these devices try to mimic some sort of pulsatility. These effects are not as profound in axial flow devices due to the steep curve, only about 3 to 7 liters flow variability throughout one cardiac cycle. Other important factors to consider in axial pumps are actually axial and centrifugal are very, very similar in how they respond to preload and afterload. They actually much less preload sensitive than the natural heart itself. One specific thing to consider in axial flow devices is, given their head pressure curve, they actually pull the hardest the lower the flow gets, meaning they're much more prone to so-called suction events. We'll get to those in a minute, what those actually are, than other devices. And due to the design, have a much higher risk of hemolysis as well. Centrifugal flow devices, as I said, also somewhat preload sensitive, but not as sensitive as the actual heart, but very, very afterload sensitive. All devices, axial and centrifugal, are much more sensitive to afterload than the actual natural heart. In fact, if you look at it, or if you remember the other slide, if you drive the pressure difference, meaning your afterload high enough, you actually can almost reverse the flow in those devices. What are the parameters that you set? Actually, the pumps operate very simple. You do set pump speed. That's just a fixed rate of RPMs, basically. The machine will then tell you what the power is. That's just basically how much current and voltage is applied to spin the motor. Another term is the pulsatility index, which basically just tells you what's the high flow minus the minimum flow divided by the average flow, giving you, again, what sort of flow variation you have in one cardiac cycle. The actual flow, what the device shows you, is actually not measured. That is estimated by the power that the device is used, meaning the lower the flow is, the less accurate that number actually is going to be. And for example, the HeartMate 2 wouldn't even show you a flow less than 3 liters for that reason. So here's an example how the monitor looks like. I'm sure many of you familiar with those kind of technologies have seen as a HeartMate 3, showing you the flow. As I said, this is estimated through the relationship of power versus flow, basically. This is the only number that you set, pulsatility index, and then the power itself is the energy consumed. Same for the hardware HVAD. This device doesn't give you the pulsatility index, which we find very important to judge sort of filling statuses and so forth. But you can actually see here, it shows you the flow variability in this flow over time curve. So that kind of is the way this device shows you pulsatility. The most important thing to remember, while some of those devices might look very different, might look very similar, the settings actually are very, very different. For example, a hardware has much lower speeds than the HeartMate 3, and both of them being centrifugal pumps. That's very important to know. You need to know both devices properly. You can't extrapolate necessarily one setting of one device to settings of the other device. Now, is there a difference between axial versus centrifugal LVADs? I'm going to present some data from the Momentum 3 trial. This trial has been going on for a long time, comparing axial versus centrifugal LVADs. This one a study group out of my hospital chaired by Mandeep Mehra. And the last report was actually just published in March of this year, so just last month. So this is basically hot off the press. And it basically shows that centrifugal pumps do perform better. They do offer the patient a much bigger or better outcomes, so to speak, in incidence-free intervals, free of strokes, or complete event-free survival. 74 is a 60% significant difference. That's one of the reasons why we more and more see, or almost exclusively, only implant centrifugal devices at this point. And if you compare that survival data with the survival data after heart transplantations, those are actually pretty much equivalent at this time. It doesn't quite comment on the life quality, but at least survival and so forth is at this point comparable to heart transplantation. I'll quickly talk about complications that you might see if you're confronted with patients with LVADs. Those are the most frequent complications that we face with: suction events, right ventricular failure. We'll quickly talk about bleeding and infection, and then pump thrombosis and neurologic events. The interesting thing about all those complications is most of them happen in the month number 1 after implantation. So if you kind of make it past 1 month after implantation, you might be well off as a patient. So first off, what are suction events? Suction events basically happen as the LVAD has a too high setting or the preload is decreased due to hypovolemia or dehydration, and the machine basically sucks over the intraventricular septum, leading to an occlusion of the device, as you can see here. This is at a RPM of 2,400 a minute. This is joined by ventricular tachycardia, so if you have low flows, a pump alarm for suction event, and ventricular tachycardia or ventricular arrhythmia, it's very suspicious of a suction event. The way you treat them is you basically reverse the cause. You do unload the ventricle less. You just turn down the RPM. You can give a little bit of fluid to kind of open up the ventricle again, offer a bit more preload. Or what you can also do is use more afterload, give an alpha agent, and that also helps you open up the ventricle itself. While they seem very threatening, they're actually very easy to fix, at least in the initial phase. Right heart failure is a big problem in LVAD patients. Incidence about 20 to 50%. Most of them actually happen in the first 24 hours after implantation, so most of this we probably do see right after implantation in a cardiac surgery ICU. The bad news about RV failure is it does increase mortality significantly. So why do these people with left ventricular failure then all of a sudden develop right-sided failures as well? Well, number one, whatever caused the left side to fail might just as well cause the right side to fail as well. And then also, as you all know, we do have a ventricular interdependence, meaning that in particular the septum has a huge part, plays a huge part in the contraction of the right side. And what an LVAD does, it moves the septum over towards the left. And what that does is it basically increases the compliance of the right ventricle while also reducing the contractility, and that might lead to RV failure. Another thing that leads to RV failure, and as you now offer more flow from the left side through the capillary system to the right side, you might actually overload the right side just with your high VAD flow. So you really have to make sure you balance your LVAD flow to right-sided pressures and the septal position. Are there any good predictors for RV failure? They will tell you which patient is more at risk than the other. A plethora of parameters has been studied. None of them really offer a really good sensitivity or specificity for RV failure. Probably the best ones actually are female gender and small body habitus. The pulmonary artery positivity index has also been discussed. I think it's a reasonable parameter for RV function, but again, none of them actually truly predict RV failure. You just really have to remain vigilant, in particular in the first few days. Management of RV failure is straightforward. You try to unload the afterload of the right heart, try to reduce the PVR, have to balance your fluid extremely carefully. Maybe even decrease LVAD flows, because again, you have to make sure you're not actually overloading the left side of the heart. And then the rest is straightforward inotropic therapy. Bleeding is an issue, or will be something you'll see quite frequently in these patients. A lot of surgical bleeding post-operatively. It is sometimes due to technical problems during the procedure. It might be that there is more bleeding than you wish to be. But more interestingly, most patients, if not all of them, actually develop some degree of acquired von Willebrand syndrome or arteriovenous malformations. The von Willebrand factor, or monomer basically, is a fairly big monomer which just gets mangled in the mechanics of the pump and gets destroyed that way. And here you can see if you actually measure it, from day one, levels are significantly reduced, and that also makes these patients more prone to bleeding. One of the big complications that you see is GI bleeds from arteriovenous malformations, and that is very often due to the non-pulsatile flow of those devices. That is one of the reasons why you always try to have them as pulsatile as can be. Here's a picture how they look like. It's very small AV malformations, very hard to clip or anything. But the management is straightforward, just like any GI bleeding management that you might see in your ICU. I highlighted this in red just to kind of let you know it is okay to hold anticoagulation in these patients for about 3 days. You're probably okay. It is standard therapy. If the patient has an INR of 3.5, which would be therapeutic for most devices, and then presents with a GI bleed or any bleed for that matter, it is okay to reverse this even, or at least hold it for a couple of days. In particular, the more modern devices actually probably require less anticoagulation than we think they do. And the rest, again, is straightforward therapy, trying to find a source to see if you can clip it through an endoscopy or a red cell tag. Infection, in particular drive line infections, that's the part that sticks out of the body and that's contact with the atmosphere, are also a big problem. Usual flora is classic skin flora that leads to those infections. There is surgical aspects that make the patient more prone to this, such as if the velour of the drive line actually is exposed to those small surgical technical issues, or a huge BMI also makes the patient more prone for infections. There is no true guidelines, or there are no true guidelines how to manage these kind of infections. Obviously, you will do targeted and very aggressive antimicrobial therapy. Sometimes just relocating the drive line might spare you from a device exchange. You can debride infected and necrotic tissue. Ultimately, the therapy you might need a device exchange. And I found this study, which I found interesting. Looking at it, is it actually always necessary to really exchange the device? Because that obviously is a huge deal to go back and change these devices. And turns out there's no benefit of doing this. As long as you have a targeted and aggressive antimicrobial therapy, you can actually achieve the same outcomes by leaving the devices in. LVAD patients also have a higher incidence of strokes, as you might know. Stroke rate is the higher your mean pressure actually is. So one of the reasons why the mean arterial pressure should be below, or is recommended to be below 90 to reduce the risk of strokes. Same thing here. It is okay to hold antiplatelet therapy or to reverse anticoagulation altogether, and then the rest is regular stroke management. Now, I just said it's okay to hold it, and here I am talking about pump thrombosis. If you hold it for too long, or more so, if you have a very hard time becoming therapeutic with your INR, or reaching therapeutic levels with your INR due to patient non-compliance and so forth, of course, these pumps can clot. This can be patient-related. This can be engineering-related, in particular the older devices. This is how they look. This would be a classic red cell clot in an axial device, and then here it's hard to see a white fibrinous clot, same as you see on ECMO circuits in a centrifugal device. What are the signs of pump thrombosis? One, the classic one is hemoglobinuria. That should be a first warning sign, or increased LDH. Elevated bilirubin, power spikes in the machine probably also are the first indicators telling you the machine is pushing against increased resistance. That might as well be pump thrombosis. This is an algorithm of how we deal with pump thrombosis. It's fairly complex, but the bottom line is this: don't hesitate, move quickly, increase your INR, increase your PDT goals, and if none of this works, go to direct thrombin inhibitors quickly. That's probably the best advice that I can give at this point. Trying to avoid pump exchange, but if you can't reverse the thrombosis, you can try fibrinolytics as well, but then actually a device exchange might be necessary, and most device exchanges that we do are for pump thrombosis. Due to the flow characteristics of an LVAD, a lot of patients do develop a certain degree of aortic insufficiency. The reason for that is usually with an LVAD flow, the aortic valve operates in parallel, meaning it doesn't get the full flow that it used to. If it gets any, it might not open at all. And here's a high-speed camera pictures of the aortic valve. This is how the aortic valve normally would open. If the flow isn't serious, obviously it won't open at all. But even if it's parallel, it doesn't fully open. It's not the same opening in here, and that leads to a degeneration or fusion of the aortic valve leaflets, and that can lead to significant aortic insufficiency. Meaning if you confronted with a patient who had been stable on his LVAD settings, but now shows up with signs of heart failure, it's always worth looking at the aortic valve again. He might have developed aortic insufficiency. One special circumstance is cardiopulmonary resuscitation in patients after LVAD implantations. The manufacturer here will actually tell you that you're putting the device at risk if you do chest compressions. Those devices can be dislodged, and if you do so, you should at least really make sure that you have imaging modalities afterwards to make sure the device is still in the place where it's supposed to be. What you can actually also do quite effectively is actually abdominal CPR in LVAD patients. Here's a case report where they did this very effectively in the operating room, as you can see, and they actually achieved under abdominal compressions, fairly reasonable systemic blood pressures. I found this study about end-of-life decisions in LVADs, and the therapy or the management of LVAD patients is extremely complex, and I think this is a true multidisciplinary team effort. We as intensivists are involved, but also so is the heart failure service. They know these patients extremely well from pre-op and then follow them through post-op. So we do share the responsibilities of those patients in the ICU. And this might look familiar to you. Sometimes as we come to end-of-life issues, we don't speak the same language. This study is comparing opinions about end-of-life decisions on LVAD patients between cardiologists and hospice and palliative care physicians, which I think very often think like us. All I want to show is we don't think alike here. It might be that they are just more attached to these patients, or as I said, they see things differently. But the point is this is a team effort. If we have differences, we need to be aware of them. We need to work through them so that the patient can be advised. If it comes to that, in the United States, the LVAD is considered life support, and hence it is ethically okay for us to actually turn off an LVAD would the patient under certain circumstances wish to do so. That's a dark note to end on, so I'll rather leave you with a picture of the sunny sky of Boston.
Thank you, Martin.